Good evening, everyone, and welcome. It's really nice to see that you've all come to hang out with us for an evening on Thursday. So my name is Dr. Goody Singh. I'm a consultant pediatrician. I'm also a broadcaster, and I'm the founder and director of an organization called the Wellbeing and Health Action Movement. But tonight, I am very proud to be here as a trustee of the Centre for Health and the Public Interest, who have brought this event together for all of you tonight. Now, I have the pleasure of being your host and your guide for this evening. So let me just take you through a little bit about what we're doing. Some of you, I think, are quite new to CHPI, and I can see a lot of students in the room, which is fantastic. And for your benefit, I'm just going to tell you a little bit about what CHPI does. Now, CHPI is an independent health think tank, and we have been promoting a vision of health and social care, which is really based on accountability and the public interest. And we've been doing that since 2012, when the Health and Social Care Act was passed. It's about what works for you, and if it's not happening, it's about holding those in power to account. That's ultimately what we're about. Now, since 2012, none of you probably need to be told about the changes that have been going on in the NHS and how both health and social care have been subject to cuts, privatizations, and a series of top-down reorganizations that have effectively left this service more inefficient and more ineffective for us as patients. And as you can see in the daily news, this is not only demoralizing to clinicians like me, it also means that patients like you in the audience are not getting the service that you deserve. Now, CHPI has been getting more and more of a reputation for the work that we do, and that's partly because we're daring to ask questions that other health think tanks are simply not prepared to do. We really are trying to hold people in power to account. And we are increasingly now featuring in the national news, and we are being given the ear of people who are in power on both sides of the aisle. And over the next year, what we want to do is to try and bring the discussion of the NHS outside of London. And so we're hosting a whole series of high-profile events in some of the UK's biggest cities. We've already done one in Manchester, and it is why we are here in the great city of Birmingham tonight. And we're really lucky to have this beautiful venue at the Exchange to be able to talk to you all. Now, it is amazing that tonight was actually a sold-out event, which goes to show about something about this topic. The fact is that we are all concerned about our NHS, and we all have skin in the game, quite frankly. If we are talking about this becoming a two-tier system, there are implications for all of us. And the question that we're asking tonight, as you can see, is how do we prevent the NHS from becoming a poor service for poor people? Now, the NHS has always been a hot topic, and ideas around its ownership and divisions around public and private are bound to be polarizing. And maybe there are even some of you in the audience who are wondering whether this is scaremongering. And what do we even mean when we talk about a two-tier system? How could this have happened? Why does it matter? And what, if anything, can we do about it? So without further ado, I'm going to hand over now to David Rowland, who will explain exactly what we mean by a two-tier health system. So please welcome him.
Great, thank you. Can everybody hear me okay? Is the sound good? Great, that's fantastic. Thank you. Well, first of all, thank you so much for turning up on such a lovely evening. It's not often the case that we get such beautiful weather at this time of year, so I feel very grateful that you sacrificed a sunny evening to come and listen to me do a PowerPoint presentation. So I'll hopefully make it as engaging and as interesting as I possibly can. First of all, I'd just like to say a quick thank you to Gabrielle, who is amongst one of the many people who've been assisting us in setting up and organising this evening. She's done a fantastic job on very limited resource that we have to bring everybody together. So before I begin, I just wanted to make that note of thank you. Okay, so really this title of the presentation came about because of the fact that during the election campaign, our current Secretary of State for Health, Wes Streeting, was very keen to point out that the NHS was in danger of becoming a poor service for poor people. And it's quite interesting because whilst it's not always the case that we've been on the same page as the current Secretary of State for Health, on this particular issue, we do definitely agree. And we've been looking at this issue for quite a long time now, the way in which the NHS was moving from a system which was intended to provide healthcare for everybody, not based on ability to pay, but based on need. And this was a concern that we had as a centre when we were first established about how the NHS was shifting, sometimes very slowly, sometimes at different moments much more quickly, with government policy, with changes in funding, with changes in organisation, away from a system which was based on this very core founding principle of the NHS. And this, I think, was very well put by Nye Bevan when he first wrote about the reasons for establishing the NHS. And there are two dimensions to it, really. I think one is about the notion of fairness, the idea that when we have a healthcare system where rich and poor are treated alike, where there is no difference in terms of access based on wealth, and that poverty is not a reason to be disadvantaged in terms of accessing healthcare, then we live in a better society. And he expressed this in terms of society becoming a more wholesome, a more serene, and a spiritually healthier place. And I sometimes think we forget that dimension of what the NHS is about. It's not just a system of hospitals and doctors and structures. It's also an idea which was put in place in order to ensure that we lived more healthy as a society, and a society that was more socially cohesive, which is something we certainly need today, and also one that felt better about itself. Now, as I've said, over the course of the past 20 years, this principle that Nye Bevan articulated has been gradually, almost imperceptibly eroded. Now, I realise that I've not put there a picture of erosion. I've got a picture of somebody slicing a salami, because I actually think that is kind of a better way of describing what's been going on to the NHS. The idea of the NHS as a universal service available to all has gradually over time shifted. And this is what Wes Streeting said about this as part of his pitch to the Labour Party conference in October last year, but also part of his pitch to the electorate during the election of this year. And his argument is that a two-tier healthcare system, where those who can afford to go private often ensures that those who can't are left behind. And that means that the NHS becomes reduced to a poor service for poor people. I think it's useful to actually look a little bit at that salami slicing, to look at how over the course of the period of time that we've been looking at this, over the course of the last 10 years or so, that we've started to see a very big shift in terms of certain areas of care where the responsibility for funding care has moved away from the collective, moved away from taxpayers, and has been pushed back onto individuals. So I'm going to start with the number of people who are having to pay out of their own resources for care in old age, primarily. Now, people sometimes want to distinguish health and social care and say, well, the NHS wasn't set up to care for people in care homes. It wasn't set up in order to provide free care for people in the community. And whilst there is an element of truth to that, I think when we're thinking about the impacts of these shifts and these changes on populations and individuals, that distinction doesn't matter. So there are currently nearly 138,000 people in care homes paying for their own care at the moment. Now that, I think, is an astonishing figure in terms of the actual volume of people who are actually having to take on personal responsibility for paying for their care. There are also people within the community, people who are receiving home care services and other community support services, who are also having to pay for their own care. So over 80,000 people who fall into that category. We also see this perhaps at the other end of the kind of the age spectrum, where we're actually seeing a very large decrease in the amount of people who are able to access fertility treatment. So going back to 2014, 40% of all IVF cycles were funded by the NHS. A couple of years ago, this had fallen to just 24%. And what we're seeing in terms of this shift is not just the fact that people are unable to access fertility treatment because of age. Sometimes that also is due to other factors, other socioeconomic and health factors, which are variable across the country. One of the things that surprised me most about doing the recent bit of research to look into this area was how quickly the NHS has shifted from being the main funder and also provider of joint replacement, so primarily hip operations and knee operations, into a situation where that is now becoming more and more common that individuals will be expected to have to pay for that themselves. So it's now the case that around 1 in 4 of all joint replacements that are carried out in this country are carried out on a basis where the individual either has to have health insurance to cover that operation or has to pay out of their own pocket. And the latest data shows that 55,000 people paid for a hip or a knee replacement recently. That's gone up from 22,000 in 2014. So what we can see there in all of these areas is an increasing push from the state in terms of its responsibility for funding care back onto the individual being required to take more and more personal responsibility for paying for their health care. And of course, we all know about NHS dentistry. When I looked at these figures, I was actually pretty surprised that on average, 74% of people were successful in getting a dental appointment on the NHS, because I've not come across very many people who fall into that category. But that's fallen very rapidly since 2015, when pretty much everybody who wanted to get an NHS dental appointment would succeed in doing so. It's also very variable across the country as well. So in certain parts of the southwest of England, it's fallen to just over half the people who want to get an NHS dental appointment can do so. We often think that the NHS is there for the more complicated stuff, and that is very much the case. So, let's be clear, the vast majority of healthcare activity and operations and treatment and diagnosis and services that are provided by the NHS. But the private sector is now starting to see opportunities to move into other areas that are of greater acuity, greater complexity. And one of those areas is cancer care. So we looked at the data around the number of people who are actually being treated for cancer care at some of the private clinics. In particular, one of the largest private cancer clinics in the country, the Christie Clinic in Manchester, which is run by HCA Healthcare. And you can sort of see that over the course of the time that we've been looking at this, from 2014 to 2022, there's been a huge increase, both in the number of people who have been admitted for day cases or for outpatient appointments. And in addition to that, you can also see the growth in the revenues that are generated by some of the private cancer providers, in particular Genesis Care as well. So it isn't just the case that those areas that we tend to think of as being issues where the responsibility has been passed back to the individual in hip operations or dentistry or fertility care or social care. It's also shifting into other areas as well, where the responsibility is increasingly lying with the individual. So, good question. How did it happen? How did we move from Nye Bevan's vision, which we all signed up to, and we all believe, I think, is forming the social contract between the people and the government about our healthcare, into what I've just described? Well, to start with, you've got to rule out certain possibilities, and one possibility is that maybe government, or one of the various coalition governments that we've had over the course of the last 10 years, introduced some Act of Parliament saying we're moving away from this principle of the NHS being a service for all, regardless of ability to pay. But I've looked through all the legislation, because that's kind of what I do for a living, and there's nothing to be seen. So there was no Act of Parliament passed. And I've also been through all of the manifestos, which I'm sure you all read before you voted at all the various general elections, and there's no statement in there saying anything other than the NHS will remain a comprehensive service, free for all, provided on the basis of need, not ability to pay. So, what's been going on? Well, I mean, I think it's quite obvious to everybody who works in the health service, everybody who's been consuming the news, everybody who is seeking to get healthcare at the moment, that we are suffering from chronic underfunding of the NHS, which has been going on for the past decade. And that chronic underfunding isn't just impacting people's ability to access care, it's also impacting the workforce, it's impacting the physical infrastructure of the NHS. But whilst sometimes in economic terms we talk about the demand for healthcare, demand for goods and services, we also talk about the supply side as well. And I think it's really important when we think about how it's possible for that number of joint replacements to be undertaken on a private basis, that we try and inquire as to how it's possible that the private sector has grown to such a large position that it can undertake such a large volume of care. So our argument really is that a two-tier system can only exist in this country with a vibrant private sector. And that is something which government over the course of the last 10 years or so has actively sought to create. So if you think about the amount of work that's been outsourced to the private sector in all the various different areas that I've described, in terms of social care, in terms of cataract surgery, and in terms of joint replacements, what you can see is that for a very large period of time, the private sector was able to grow and expand on the basis of the income that it received from the NHS and from taxpayers. So if we look at how much the NHS was spending in the private sector in 2018, it was about £15 billion a year, and this has risen to about £20 billion a year in the last period of the accounts that are published. And it's not just that the government has been outsourcing increasing amounts of work to the private sector, it's also permitted the private sector to exist on the back of significant subsidies that have been provided by the state, in particular the use of NHS consultants to carry out a lot of those operations that I've just been talking about. It also provides subsidies in terms of ensuring that when something goes wrong in a private hospital, that the NHS is there to ensure that the patient is treated. And understandably, businesses, as they are, will look at the state of the NHS and look at the opportunities that are being provided to them by government and seek to make the best of them from their own perspectives. So this is something that has been going on for quite some time. So this is a quote from JP Morgan back in 2017, which identified opportunities for the private sector on the back of the current government approach to health policy, which was to restrict the amount of money which went into the NHS, and also to recognise that government would continue to outsource care. And what that insight has led to is something that we'd like to describe as these private companies really betting against the ability of the NHS to keep meeting the population need. And that bet is obvious and manifested in the very large amount of capital investment that we've seen in for-profit healthcare facilities over the course of the last 10 years. So whilst very many NHS hospitals have not received very large amounts of capital investment, if any, we've seen that over £2 billion has been invested since 2014 in ophthalmology clinics, cancer centres and other hospital facilities. So it's not just that the private sector is seeking to engage with the status quo as is, it's seeking to expand on the basis of the income that it's received from government and also the opportunities which exist as a result of the chronic underfunding of the NHS. Now, it's quite interesting coming to Birmingham because I think one of the things that you can see is in a sense where these two trends are starting to converge. So on the one hand, you've got NHS hospitals which are really struggling financially, and you've also got private companies that are seeking to exploit the demand that is created as a result of the NHS hospitals struggling. So what has happened is that you've seen these two trends of the private sector expansion and also the reduction in the amount of money available to the NHS converge. And you see that obviously on NHS campuses where those big hospitals in large urban centres have partnered with private hospitals. So the new hospital which is opened on the Queen Elizabeth campus with HCA Healthcare is as a result of the fact that the NHS doesn't have the capacity or the capital to be able to expand itself, and it has partnered with an American healthcare company in order to be able to offer private healthcare to the local population. Now, interestingly, some people are arguing for much more of this type of thing to happen. So, because of the fact that the government is committed to not increasing the amount of borrowing that it takes on, people are thinking, well, actually what we need to do is to bring in the private sector, to bring in private sector investment. It's seen as the only option, which was actually the argument that was put forward when the private finance initiative was introduced over 20 years ago. But we'd argue this is a pretty high-risk strategy, and it's a high-risk strategy because of what I would call the pivot, which sounds like a podcast, but is actually the idea that once the private sector has grown to a certain size using NHS resources, it no longer needs to treat NHS patients, but can instead focus on those who can afford to pay privately. Now, we've seen this in social care, for example. So the first time I came to Birmingham 20 years ago was to do a study of how the local authority, the city council, was having to move its care homes out of local authority control and into the private sector. And that was something which was happening up and down the country. And it's now the case that pretty much all care homes in the UK are owned by for-profit companies, and they're increasingly less interested in treating state-funded residents because private payers pay on average about 40% more. So what you're starting to see is in those parts of the country where there aren't as many private payers, you're starting to experience what are known as care deserts, which is the same terminology we talk about when we refer to dentistry. Joint replacement, again, is an interesting dimension to this. So what we've seen over the course of the past 10 years is that the NHS has allowed the private hospital sector providing joint replacements to expand. It's now in a situation where it's increasingly turning around to the NHS and saying, well, actually, there are quite a few people out there who need our services, so we don't really need to continue treating you guys anymore. And so that really is a way in which the two-tier system and the problems behind it become exacerbated, because it's not possible always to require the private sector to assist the NHS in perhaps the way that the current government thinks it will, because the private sector, from its own business perspective, will seek to focus on those patients which are most profitable. So, based on our research, we don't think it's possible to prevent a two-tier system by growing the private sector. In fact, experience shows it will probably make it much worse. Just want to sort of recap a little bit on why a two-tier system matters before we move quickly into what are the potential options available to us. I think the first thing about this that isn't really often said is that at the heart of a two-tier healthcare system is one that is both unfair and discriminatory. And when you've actually looked at the data relating to people who are able to access NHS-funded care in the private sector, they tend to primarily benefit those people who are white and those people who are from wealthier backgrounds. So inherent in the use of the private sector, as has been identified by various pieces of research, is a system which is effectively discriminatory and unfair. The other dimension, which I think is probably something which some people in the audience who've had horrendous experiences of treatment in the private sector and also seeking redress, is that it actually exposes people who are forced to go private to what are known patient safety risks. And we've documented these at length in other areas, so I won't go into them now. But it's something which not very many people are aware of, these regulatory loopholes that exist. And those regulatory loopholes around safety in the private sector are also potentially exacerbated by the fact that there are regulatory loopholes relating to how people are able to afford and pay for healthcare in the private sector. So if you don't have health insurance, often people are required to take out personal loans. Some of those personal loans and the opportunities that are available to people on cheap credit arrangements, buy now, pay later arrangements, expose them to financial risk. I think from a longer term perspective, we need to recognize that if we have a situation where people are paying out of pocket for their healthcare or they're taking out private health insurance, they are over time less likely to be committed to the idea of the NHS. And that's because of the fact that often it's the middle classes who are going to be asked to pay more money in order to be able to ensure that the NHS can meet up with demand. If you're also paying out of pocket for your own private treatment or for private health insurance, how willing are you to be able to want to pay for higher taxes? The final point, which I think is something which perhaps Wes Streeting didn't quite get when he was talking about the NHS becoming a poor service for poor people, and that is that the NHS, when it is faced with the private sector entering into a particular area, so we've seen this within the cataract sector and ophthalmology, that it will sometimes be the case that the local private clinics will make very generous offers to the NHS consultants to come and do private work down the road. And from the consultant's perspective, that's obviously a big dilemma for them. But the consequence of that is that the NHS departments are therefore left with fewer staff to be able to treat often the more complex and the more sick and often the poorer people. So it's that mechanism by which the NHS becomes a poorer service for poorer people. It's the idea that the private sector isn't just adding capacity to the NHS. By its very existence and by the fact that the private sector has grown to such a degree and is able to pull NHS consultants away from the NHS, it is also potentially undermining the ability of the NHS to meet the needs of the population. So what can be done? Okay, so this is, I think, something which we may have seen headlines about last week. The NHS is in an absolutely terrible state. A report comes out, says that. And then the approach that's been taken by the government at the moment is to say there won't be any additional funding without reform. Now, I think that just kind of leaves the question hanging, really, because unless there is a clear commitment to increasing the amount of resources that go into the NHS, most people would say that the NHS is on a very, very slippery slope towards something which is much, much worse than what we're currently facing. But we're not clear what reform looks like. We're not clear how it's possible to change the system in such a way to be able to meet the needs of the population without actually increasing the amount of resources that is going into it. So if anybody's got any ideas about what reform might look like and how it might be able to save the NHS, then please do speak up in the Q&A session. I was trying to think how, if you were confronted by this problem of a two-tier system, what you would do. And actually, there was a decision taken, a cross-party decision taken in the Republic of Ireland, where there is an institutionalized two-tier healthcare system to do something about it. And I think that's a really interesting example of where there was a recognition that the healthcare needs of the population were not being met. It was a shared concern across all of the political parties, and there was a commitment that was taken by all of those parties to have a 10-year plan to be able to address this situation permanently. Now, I'm not suggesting that they've got this right or that the approach that our current government has got it wrong, but I do think it's sometimes important to think away perhaps from the kind of technocratic reforms that we are currently often focused on, and to be starting to think of something a little bit more big picture. Irrespective of what happens with the reform of the NHS and irrespective of what happens with the funding for the health service, our research has shown that it's very important that we start thinking differently about private sector involvement and the role that the private sector plays, not just because of what I've spoken about in terms of its likelihood in furthering and exacerbating the two-tier system, but also because of the risks that I've identified as well. Now, we've got some solutions that we've set out in some of our other publications, which really are designed to ensure that the regulatory loopholes which expose patients to risks of harm are addressed, and perhaps as importantly, that where private companies are actually delivering services to the NHS, that they're tax registered in the UK, and that the amount that they actually generate from healthcare contracts is a reasonable rate of return. Okay, so I don't want to end with too much doom and gloom, but I think it's important to recognize, first of all, the importance of funding. I think it's important to recognize that we've got a problem, But I also think it's important to recognise that the trajectory of the NHS that we've been describing is not inevitable. It is the product of political decisions of which we all have a say. And importantly, it's been done before. So we're not starting from a position of we don't know how to do this. We are very fortunate to have been born into a healthcare system which had, at its founding principle, the idea that healthcare should be provided on the basis of need and not ability to pay. So thank you, and now we can now move on, I think, to the next bit, which is the question and answers and the discussion.